position, we can determine the vibration above the scapula, between the scapulae, and below them. For estimation of elasticity of the chest, at first, press in the anterior-posterior direction, then from the sides. This method is less informative because the elasticity, which is determined in such way, depends only slightly on the elasticity of the lung tissue. Percussion of the lungs. In the year 1761, the Austrian physician Auenbrugger proposed and described the method of percussion. The son of an inn owner, aspired to be a physician, watched his father estimating the level of wine in the barrel by knocking on it. This has become the basis of the percussion method, which is still valid today. There are several different types of percussion tones. Two of them are the basic ones. Dull percussion tone is produced during the percussion of absolute aortic organs, for example, the liver. This tone is high, short, and thud-like. Tympanic tone is produced during the percussion of hollow organs, for example, on the sides of the abdomen or in hollow areas such as the gastric bubble. Tympanic tone is loud, long, and drum-like. Its pitch depends on the degree of tension of the surrounding organs and cavity-limiting organs. Between the two basic tones, there are three other tones. The resonant tone of the lung is loud, long, and low. There are also flat and hyperresonant tones. While carrying out percussion, it is necessary to follow some rules. Firstly, the pleximeter finger, that is the left middle finger of the examiner in right-handed persons, must be firmly pressed to the body of the patient. Otherwise, the percussion tone will not be distinct and will not reveal the real condition of the tissue. Secondly, movement of the right hand must be carried out only at the wrist joint, and the forearm remains fixed. In the past, physicians performed percussion by using a tendon hammer knocking against a plate made of metal or ivory. However, today, no one uses this method anymore, but percusses using the finger-to-finger method. There are two types of lung percussion, comparative and topographical. The purpose of comparative percussion is the evaluation of the character of percussion tone. One way of comparative percussion is alternating right and left side positions. The examiner faces the patient and asks him to turn his head slightly to the side and percusses as shown. This method of percussion ensures an equal distance between percussion points on the right and left hemithoraces. Initially, percuss anteriorly above the clavicle, later on the clavicle. In this case, the clavicle serves as the pleximeter. In turn, on the right and left midclavicular lines until we reach the third intercostal space. On the right side, percuss until a dull tone. During percussion on the mid-axillary line, ask the patient to place his hands on his head. While percussing the posterior wall, ask the patient to bend his head slightly and cross his arms in front. Percuss above the scapulae, between the scapulae, and below them. Normally, we hear a resonant tone above all the areas of the lungs. Topographical percussion includes determination of the upper borders of the lungs anteriorly and posteriorly, lower borders of the lungs, and the excursion, that is, the mobility of the lower borders. It is important to remember that markings must be made on the side of the pleximeter finger facing the starting point of percussion. Determination of the lung apex anteriorly. Place the pleximeter finger above the clavicle and percuss upwards parallelly to the clavicle. Ask the patient to turn. Place the pleximeter finger above the spine of scapula and percuss upwards in the direction of the hairline. Measure the height of the lung apex anteriorly above the clavicle. Normally, it is 3 to 4 cm above the clavicle. The height of the lung apex posteriorly is approximately at the level of the spinous process of the 7th cervical vertebra. And now, we estimate the lower borders of the lungs. Initially, on the right side, on the parasternal line. Normally, the lower border is located on the lower edge of the 5th rib. On the mid-clavicular line, it is on the lower edge of the 6th rib. On the anterior axillary line, on the lower edge of the 7th rib. On middle axillary line, the lower edge of the 8th rib. On posterior axillary line, the lower edge of the 9th rib. On the scapular line, the landmark is the angle of the scapula, which covers the 7th rib. The lower border is on the level of the upper edge of the 10th rib. On the paravertebral line, the landmark is the 7th cervical vertebra, and from its spinous process we go downwards. Normally, the lower border is on the level of the spinous process of the 11th thoracic vertebra. Now, we estimate the lower border of the left lung. Initially, on the parasternal line. Normally, it is located on the lower edge of the 4th rib. We do not estimate the lower border on the left mid-clavicular and left anterior axillary lines because it is hindered by the tympanic tone from the semilunar space of throb. Next, we estimate the lower borders on the corresponding lines as in the right side. Now, we estimate the mobility of the lower borders of the lungs. Usually, we perform this either on the posterior axillary line or the scapular line. Ask the patient to take a deep breath and hold it. From the lower border of the lung, percuss downwards until a dull tone. Later, after a few calm respiratory movements, ask the patient to make a maximum expiration and hold it. Percuss again from the predetermined lower border of the lung upwards until a resonant tone. Place a marking on the lower edge of the pleximeter finger. Measure the distance between the levels at which the tone change occurs. Now, on the left side, ask the patient to take a deep breath and hold it. Percuss downwards until a dull tone. Make a marking on the upper edge of the pleximeter finger. Later, ask the patient to make a maximum expiration and hold it. Percuss upwards until resonant tone. Place a marking on the lower edge of the pleximeter finger. Measure the distance between the lower border of the lung during inspiration and expiration. Auscultation of the lungs. We auscultate the lungs at the points of comparative percussion. Ask the patient to breathe with moderate depth with half-opened mouth. Usually, to obtain optimal result, auscultate the patient in the sitting position. Auscultating in the standing position is not preferred because deep breathing may cause hyperventilation and result in dizziness. To recognize adventitious breathing sounds such as crackles and crepitation, ask the patient to breathe deeper with half-opened mouth. While to listen to basic breathing sounds, that is vesicular or bronchial breathing, ask the patient to breathe with moderate depth through the nose with his mouth closed.
Пацієнту пропонуємо дихати глибше, напіввідкритим. А для того, щоб оцінити основний тип дихання, бронхіальне, вестибулярне дихання, пацієнт дихає через ніс закритим.
Bronchophony. Bronchophony is the auscultation of whispered sounds on the previously shown auscultation points. Ask the patient to whisper some words containing the sounds ch and sh. For example, Spanish cherry. Normally, we do not hear these words except the sounds of th, sh, ch. In consolidation or inflammation of the lung, the whispered words Spanish cherry are heard distinctly.
Прошу казати. Шепотом, не голосом. Добре.
In this patient, all what we hear is s, sh, ch, and not Spanish cherry.
Серцево-судинна система.
Cardiovascular system. Palpation of the heart region. Palpation of the heart region is used for determination of the apical impulse, the heart lift, and thrills in the heart region. Palpation of the apical impulse is performed in 3 steps. First step. To locate it, place the right hand in such a way that the right middle finger is placed on the 5th intercostal space. When you feel an impulse beneath this finger, the finger is correctly placed on the apex. Second step. Rotate your hand as shown, so that the fingertip of the right middle finger is placed above the center of the apex. Third step. Point out the center of the apex. Palpation of the heart lift. Normally, the heart lift is not palpable. It is palpated in case of intensified work of the right ventricle. The next step is estimation of thrills in the heart area. Diastolic thrill is produced by mitral stenosis. It can be felt on the area of the heart apex. Systolic thrill is produced by stenosis of the aortic orifice at the area of the second right intercostal space, or stenosis of the pulmonary artery orifice at the area of the second left intercostal space. Sometimes we can palpate the pericardial friction rub. Percussion of the heart. Percussion of the heart includes locating the borders of relative dullness of the heart, borders of absolute dullness of the heart, width of the vascular bundle, determination of additional points on the right and left contour of the heart, estimation of the angle of the heart, sometimes also called waist of the heart, estimation of the heart configuration. Before estimating the borders of relative dullness of the heart, it is necessary to locate the position of the diaphragm. On the right mid-clavicular line, percuss downwards until a flat sound, not to dull sound, but to flat sound. In this area, the lung tissue still covers the liver. In a normosthenic individual, the diaphragm is located normally on the level of the lower edge of the fifth rib.
У нормостеніків висота стояння діафрагми знаходиться.
Move upwards by one intercostal space. Turn the finger for 90 degrees and percuss in the direction of the presumed right border until a flat sound. Next, we estimate the left border of relative dullness of the heart. First of all, it is necessary to locate the position of the apical impulse. Move 3-4 cm to the left from the position of the apical impulse. Percuss in the direction of the apex. If the apical impulse cannot be palpated, then percuss from the left anterior axillary line. Next point is the upper border of the relative dullness on the parasternal line.
Біля грудинної.
Next step is the estimation of the absolute dullness of the heart, that is the part of the heart which is not covered by the lungs. Percuss from the borders of relative dullness gently until a dull sound.
Межі відносної тупості серця, тихої перкусії, до тупості.
In most cases, the left borders of the absolute and relative dullness coincide. Anyway, it can be located. In this patient, there is no big difference. And estimate the upper border of the absolute dullness of the heart.
Це є ділянка серця, яка не прикрита.
This is the area of the heart not covered by the lungs, the area of absolute cardiac dullness.
Ширина судинного пучка.
Width of the vascular bundle. In the second intercostal space, from the right and left midclavicular lines, respectively, percuss in the direction of the sternum very gently. It is necessary to stress that while estimating borders of the relative dullness of the heart, we percuss with moderate strength until a flat sound. While for determination of the absolute borders, percussion must be gentle and we percuss until a dull sound. Next, determine additional points on the right and left contours of the heart. Additional point on the right heart contour lies in the third intercostal space. In the second intercostal space, the right border of the vascular bundle is located. In the fourth intercostal space is the right border of relative cardiac dullness. On the left, we determine the additional points on the third and fourth intercostal spaces.
І в четвертому.
Connecting these points, we estimate the right and left contours of the heart which form the cardiac silhouette.
Серце.
On the left heart contour, we estimate the angle of the heart, also called waist of the heart. The angle of the heart is the angle between the vascular bundle and left border of left ventricle. Normally, this is an obtuse angle.
Коли збільшується
When the left ventricle